I don't know if I broke up there. I'm sorry about that, but I'm very excited to co-discuss with Ravi, and I want to introduce Dr. John Black, who's a fellow hospitalist. John, if you want to unmute and kind of introduce yourself. And in the meantime, while John is introducing himself, if anyone wants to join the co-discussion party between me and Ravi, please let us know.
Okay. All right. Yeah. Thanks for having me for the case discussion today. Now, I'm John Black. I'm an academic hospitalist, medical educator in Pittsburgh with Allegheny Health Network. I am a coffee lover, cat enthusiast, avid gardener, and things I love. I love doing hospital medicine and medical education. I think teaching really makes you a better doctor, keeps you on your toes, and ability to always takes your knowledge to the next level when you have to be able to explain things on a deeper level. And love hospital medicine. Kind of love, one of the things I love about it is the variability of the different hats that I wear, and I love the just kind of sometimes just being the quarterback of communication in a complex healthcare system with people come in overwhelmed, hear a million different things from different people, and just taking all that and distilling it into normal English. Sometimes even if we're not the ones, managing the specific problem, we can be the specialist in communicating and making it all understandable. So I've got a case to present today that was one that I learned a lot from, and one that I kind of pushed me out of my comfort zone in 3 different directions at the same time. So that's why I wanted to share it. So for some context, I work at 2 different hospitals. One of the ones I work at, where I spend the minority of my time, we're responsible for doing the stroke alerts. And so I don't really do them often enough to truly feel at home or feel comfortable. But it's always something that keeps me on my toes when one gets called. So kind of continuing on the theme, I can't remember what date it was, but we had one of the recent morning reports start off as a code stroke. So I'm going to continue that theme, but just take it in quite a different direction than the way it went last time. All right. So with that, you ready for me to share the first aliquot?
Absolutely. Absolutely. I just want to jump in there before, John, you just mentioned gardening, and my activity after this is to go feed my trees. So I just bought some fertilizer from Costco, and I will go out and feed my trees. So just to make you proud there.
Nice.
All right, let's go.
Okay. All right, so our first aliquot of information will be stroke alert is called to labor and delivery triage. Now, so most of the time when I get called there, it's sometimes not for the mom, but for the father of the baby. They have a vasovagal syncope, and then I feel a little bit more comfortable. But that wasn't the case this time. So I arrive on the scene. So let me preface this. So some of the aliquots are a little bit out of the traditional order, but it's kind of replicating real life and the order in which we got things. So I walk in the room. I find the patient is a young woman. We'll say she's a 26-year-old female. She is pregnant at approximately 18 weeks. And notice the OB-GYN team is at bedside, and they're communicating by way of translator service. And the translator on the iPad says the dialect isn't quite right. So they're having trouble understanding each other. So a little bit of a limited history. So we've got a language barrier, a pregnant patient, and a stroke alert at the same time. So I'm pushed out of my comfort zone 3 different directions all at once. So the father of the baby is present at bedside. So the complaint is burning and numbness in the right side of her body. This has been going on for 3 to 4 days. She's been very fatigued and generally weak, with enough severity that the father of the baby has been helping her ambulate around their place. So there's about 1 week prior to this, I'll log in the chart to see she was in the emergency department for headache, fatigue, and some low back pain. Had a hemoglobin of 9.5 at that point. Symptoms were attributed to pregnancy and anemia. She was, discharged with conservative management, no imaging at that point. I'll take you back to the the first paragraph for the scribing is we've mentioned the other component of the HPI is that she's had some difficulty speaking, that seems like she's having trouble finding her words. So we'll get just kind of the first pass on the exam as to conclude the first aliquot. So her heart rate is 97, blood pressure 105/62, temperature 37.2. She's setting 94% on room air. General, she's no acute distress, just understandably anxious appearing, well nourished. HENT exam, kind of just mucous membranes moist, nothing to write home about. Regular rate and rhythms, no peripheral edema, lungs sound clear. Fetal heart tones are present, rate around 140. For her neuro exam, she's awake and alert. Her face is symmetric. No obvious dysarthria when she's speaking with the translator. Was able to give good effort, 5 out of 5 strength throughout, and she has diminished sensation to light touch in her right lower extremity throughout. Otherwise, no other obvious focal deficits picked up on my first pass. So
Okay.
I think I'll conclude that aliquot there, and just I'll plug a little like throwback to whenever we get called stroke alerts. So a lot of them are called for a sudden change in level of consciousness or stroke-like symptoms. I think the scan mnemonic is a helpful one to review at this point if one of the discussants can kind of take from here, and I'll mute myself and turn the reins over.
Thank you, John. Absolutely wonderful start to a problem. And nothing's more scary than being called for a rapid response in labor and delivery. So this kind of takes me back to simulation. I do quite a bit of simulation, and I do have a couple of cases, but nothing to this degree or complicated as this. So what I'm interpreting this as, I'll just sort of start off, Jasdeep, with what exactly is going on here. So before even doing a deep dive, when we get to the bedside, you've been called for a patient is coming in with numbness and then having some trouble understanding, or the translator service having trouble understanding the history. So maybe some issue with mentation there. But then there's these non-specific symptoms of fatigue, weakness, and the father of the baby has been helping with then kind of emphasize ambulation. So a 26-year-old having trouble with ambulation, but you're not far along in your pregnancy. So I think like second trimester, 13 to 28 weeks, and here we're at 18 weeks. So second trimester, shouldn't they be having issues with ambulation? So this requires a bit more of a deep dive into maybe a neurological examination of the legs to see if there is an issue with maybe muscles, nerves, or anything impeding the movement of the lower extremities. And then there's headache, and along again with fatigue and back pain. So now you're sort of building this narrative. You're extending from the back, from the head back to the legs. And then you have to add or subtract the pregnancy. Do we have to start thinking of pregnancy-related complications, or is this something that's totally separated from the pregnancy? Now, if I go down the path of maybe pregnancy-related complications, things that come to mind, people start thinking, okay, amniotic fluid embolism, but that happens at delivery. What else could you have? It can be a highly thrombotic state as well. So thrombosis, and you get thrombosis anywhere, CNS thrombosis in the vessels, in maybe the inferior vena cava, and lower extremity weakness could develop as a sequelae of that, but we're not getting a sense of any edema, but we haven't got the full exam. But those are a few things. But before even jumping to the diagnosis, what exactly are we dealing with here? And when you have a rapid response, you have to start thinking about corrective measures or measures to at least prevent any degradation or deterioration of the patient. So this is kind of called a back code where we are, or rapid response. It could be back code will be brain attack. You have stroke-like features, or rapid response. Both will pull an emergency team consisting of a resident, ICU nurse, and several other components of that team to the bedside for an urgent evaluation, plus neurology to determine if we need to do a scan. Also to consider if TPA administration, if the risk assessment score, whatever risk assessment score they use, is highly in favor of possible stroke, and then you need to implement thrombolytic therapy. Plus, you have to weigh in some contraindications to thrombolytics. So definitely there's something going on in the brain. What is it? I'm not sure, but that's where I would start my focus. But I'm not going to keep going on. I'd like to pull Jasdeep into this conversation, see what he's thinking about.
Thanks, Ravi. That was brilliant. Honestly, I think this is, first of all, John, what a great presentation, and I feel like there's so much to peel away here that I'm trying to see what's signal and what's noise. The first question I would ask myself, and I agree with Ravi that when you're seeing this patient in a hospital, you're going to obviously do stroke code and kind of make sure that we urgently make sure that this is not something like a vascular clot that could be reversed. However, there's certain things that now we have the benefit of looking back in hindsight, that makes me pause. Why is a 26-year-old female having burning sensation and numbness? Is it all from a stroke? It possibly could be, but 3 to 4 days, that's where I pause. And it seems like it was diminished sensation to light touch in both extremities, if not just the lower extremity. It could be one or the other. That would be an interesting presentation. And I wonder about the possibility of the spinal cord being involved here, because the difficulty speaking and finding words, that could be possible due to a vascular event. But what I wonder about here, why I bring that up, is in pregnancy, back pain is very common. What also is very common is sciatica, due to the uterus growing and pushing onto the structures in the lower pelvis. And the other thing I would want to add is, I'll never forget a case that a colleague shared with me, a colleague and a friend who, we were seeing this patient in the outpatient setting for prenatal visits, and she was telling how her back pain was getting worse despite trying to see the minimum schedule, despite doing all of these possible therapies that we were recommending. And almost every provider would say, this is just related to your pregnancy related changes, except for when one physician decided to get an MRI of the back, and unfortunately for the patient, it was metastatic breast cancer. That was met to the spine. So I think when traditional schemas don't fit, even though it could be explained by pregnancy, if there's some red flags, it's worth exploring. Already what I'm seeing here is this is not consistent with pregnancy related changes. Could this be pregnancy leading to an increased risk of clotting? Yes. However, most complications in pregnancy, like preeclampsia, like increased risk of stroke, doesn't happen until third trimester. For example, preeclampsia can begin up until week 20, but usually the vast majority of them is actually week 34. And remember, preeclampsia can actually happen 4 weeks after postpartum. So it's one of those things that can creep up even after the pregnancy is over, but usually happens later in pregnancy. Same with vascular complications, cardiomyopathy, the list goes on and on. So now I'm wondering here, is this a non-pregnancy related thing that we may be focusing too much on the pregnancy aspect? It's possible, but I would first want to rule out stroke. Couple things I want to highlight. To be honest, I'm not too concerned about the low blood pressure and the anemia, at least currently. Both anemia and the systemic vascular resistance is lower in pregnant patients. So I don't think that's signal right now, but I would love to hear more from John to see what else there's to learn from.
All right, yeah, great discussion. So I'll try to answer a couple questions from your set. So from just clarification in the HPI, she was kind of, repeating like my right side's numb, right? My right side's numb, but it was on the exam, we appreciated the sensory deficit in the lower extremity only, not in the upper. So, and I think she wasn't getting any, tocolytics or, she's like anyone who is pregnant at this, this facility kind of goes directly to the L&D triage for the first pass. All right. And just a couple like throwback things, the scan mnemonic where you're checking the sugar, C for CT, thinking like, is this a patient where I need to consider urgently getting CT scans? A for, arterial blood gas, reminding you that, is this somebody who do I need to worry about CO2 retention? Do they need positive pressure therapy? And so the kind of helps the mnemonic fits into like calling, these stroke alerts too. And the N for like, Narcan, do I, remind you to look at the pupils and to look at their medication list. All right, so next aliquot. So we talk with the OBGYN team at bedside. They remind us that, the pregnancy increases your thromboembolic risk. And they said, like, if you have any inkling of stroke, if she was not pregnant and had these symptoms, would you be getting CT scans? If yes, then the risks, the risks are going to outweigh the benefits are going to outweigh the risks. So like, go ahead and get this done. So that's oftentimes for like whenever you respond to a stroke alert, we prioritize getting them to the CT scanner as fast as we can. And a lot of times that comes before sometimes even getting the complete history and, limitations of your exam. So we make the decision to, go ahead and get a CT scan of the head and the, CT angiogram of the head and neck as our first pass, along with a, glucose value, which was normal. Just remember like that the previous morning report where we started off as a code stroke was hypoglycemia, and the hypoglycemia can really mimic stroke-like symptoms. So it's one of the first things I do in my first pass responding to a code stroke while I'm, getting a, quick review of the chart in the neuro exam. So we have a CT scan of the head, no acute intracranial abnormality, but I get a call from the radiologist and they say, there's no large vessel occlusion, but we saw part of the top of the lungs while we were doing this CT scan, and there's innumerable pulmonary nodules throughout the included part of the lungs. So at this point, let me try to just share my screen, see if I can show you a picture. All right. A sample of it. Everyone see it? All right, so I'll go ahead and if everyone's gotten, just give a few seconds to take a look and then I'll stop my screen share.
Seeing, just to sort of describe it, and I'm sure you have the interpretations, a lot of fine, rather than large nodules, a lot of fine dispersed nodular infiltrate. Is that what they mentioned?
Mm-hmm. Yeah, so I'll stop the share here. And so anyone like we had a morning report not too long ago. Jack Penner shared an approach to pulmonary nodules. If there's anyone, if anyone even in the chat wants to kind of come back and share that, or one of the discussants, maybe a good throwback pearl, and kind of see what you think about which category that this would fit into. So let me ask you, like, what you get this call from the radiologist, what are some of the first steps you would take? How are you approaching triaging this patient?
I think Tansu just mentioned, just to sort of talk about what I saw. It almost has a miliary pattern. I think Jasdeep mentioned looks like TB, but that just comes to mind. But you have to do your due diligence and kind of work through what could possibly cause nodular infiltrate. So we do kind of talk about anatomical approach, or I kind of have an approach where I just think about what could it be. So we have our bucket of infections, we have inflammatory lung conditions, autoimmune conditions. You could have tumors, and you could have tumors that could be benign, metastatic. You could have primary lung cancers as well. And you can have also nodular formations as well, which could also be of the inflammatory kind. But I like what Tansu had kind of mentioned. Are you able to unmute and go through the anatomical approach?
Yes, I can do that, certainly. Thank you so much, Dr. Ravi. So as Dr. Jack Penner taught us a couple of weeks ago in the VMR, we have three different patterns when we look at the lung nodules, and our reference is the bronchioles, interlobular septa, and the visceral pleura. So we decide where the nodules stand in relation to those three anatomical structures. In the centrilobular pattern, the nodules are distributed at the end of bronchioles, as far as I remember, because those nodules are distributed through the airways. And in this category, we have infectious diseases that are like inhaled from the respiratory tree, like TB, bacterial or fungal infections. But we can be looking at any other infectious process too. And in the perilymphatic distribution, there are many nodules, like usually touching the interlobular septa and the pleura. So in that, we are looking at silicosis, pneumoconiosis, other pneumoconioses, and in the randomly distributed nodules, there's no pattern in relation to those structures, the anatomical structures that we talked about. And in that category, we are thinking about metastatic diseases to the lungs, malignancy, or miliary TB, or histoplasmosis, for example. Yeah, that's what I recall from that session.
Absolutely wonderful. I just want to add to that wonderful list. What we may commonly see somebody 26, 18 to 26, maybe even younger, is vaping, even valley present in this manner. I even had a patient with pulmonary talcosis have a similar presentation. So like you mentioned, any sort of inhalational injury could present like this, but absolutely wonderful breakdown. Jasdeep, I want to sort of pull you in and see what you have to think about this.
No, honestly, after Tansu's breakdown, I don't have much to add. I think the only question I would ask the radiologist here, because I'm not one myself, is this nodules in a random or perilymphatic distribution? Just by looking at that CT scan, it's kind of hard to tell just because it's like a still picture and not like a motion. It doesn't look like it's clustered into like a lymphatic distribution. So if it was, I feel like, lymphoma, there's a great case that I co-discussed with Andrew that was actually like lymphoma, T-cell leukemia actually. So that could lead to it, sarcoidosis and pneumoconiosis and stuff like that. But if it's more of a hematogeneous spread to leading to nodules, then like you said, Ravi, infection is the most likely possibility. And I agree with other people who mentioned like metastatic cancer, but just using base rate of disease, 26-year-old female, I would probably be more concerned for infection and would rule that out before I go down the bucket of metastatic cancer, even though I just shared a cancer example in the prior aliquot. I think this patient is concerningly sick, and I think this may be like because like I would use this as the turning point in the case, and I guess why behind that is because so far the picture that we were getting painted for was the fact that this patient was having neurological symptoms, and then bam, all of a sudden this like pulmonary nodules came into the picture. So I would wonder if this may have more of a if this where there's smoke there's fire. I wonder if this might be worth chasing and probably less likely to be noise.
Absolutely wonderful thoughts there, Jasdeep. I just enjoying discussing this with you. And like you mentioned, very important to think about base rate. And when John can probably relate to this, when you are on a busy service, you don't have the capacity to sit and think and just kind of work out long lists of differential diagnosis. So you have to make a patient-specific differential diagnosis. So who is the patient, 26-year-old I don't get any signal of immunocompromised status. Say there was HIV, maybe there was malignancy on chemotherapeutics. But this excludes a lot of the sort of atypical infections. And do we even have a signature infection? I'm not sure yet, but we still have to consider that. So if I was compiling a list of causes, definitely infections are there. But you have to also think about infections and CNS, presenting with a CNS disorder. So this problem representation that we're building. So when you have this complexity, this much complexity of a patient, I think generating a problem representation can help us solve and highlight key features that can help us to get to the answer for this case. So 26-year-old, and there's no real past medical history. I guess the past medical history is this pregnancy, and so far hasn't been a problematic pregnancy. And John, no issues with prior pregnancies or anything like that? Do we know if there's been any spontaneous abortions or anything like that before?
Yeah, so no prior spontaneous abortions, or it's her first pregnancy. So I'll share some additional history in the next aliquot. But so after I got that call from the radiologist, I rapid fire made a few different phone calls pretty quickly. One was to a charge nurse in patient placement to say, actually, whenever, the first thing to think about is also just kind of protecting your staff. And I was like, you need to get this patient into a negative pressure room. Because like everyone, people, whenever you have any inkling of, tuberculosis, always have to quickly get the patient into precautions until you've had time to digest and really risk stratify how likely that is. And I talked to the radiologist. I was like, okay, we saw part of the chest. How about while she's in there, let's finish the CT scan of the chest and take a look at the rest. So that's the next aliquot. It's a little bit more history, and the dedicated CT scan of the chest is what came next. So the patient and her husband are from Afghanistan. They moved to the United States about 6 months prior to presentation. They're staying in a hotel nearby, and haven't had any regular prenatal care prior to coming in, and it's her first pregnancy. No significant past medical history other than she was treated for some type of chest infection, is what we're told at the time, 2 years ago with antibiotics, but we don't really know what that was or what she was treated with. No stick contacts, no other travels, no animal exposures. Just not taking any regular medications. No tobacco or alcohol or recreational drug use otherwise. Okay. And so for the dedicated CT scan of the chest, so innumerable pulmonary nodules diffusely throughout the lung fields, described as being in a more random pattern. And there's also some small, mediastinal and bilateral hilar lymph nodes, measuring not huge, but 7 millimeters. That's one of the ones. So I think that's where I'll turn the reins back over for some more. How are you digesting this?
Yeah, Steve, you want to take a stab at this?
Yeah, I think there's a lot of concerning features here. I think John, you mentioned this last time too, like what would we do in real life in triaging this patient? I think the first, after we know this patient is now stable and not having a stroke, I would actually make sure the patient is in isolation and making sure all the staff is taking care of us with N95 masks. I think the one thing that took away from the patient has a geographical risk factor of being from the Middle East, where we know that certain types of endemic mycoses, yes, can definitely be present there, but TB is notorious to be in high proportions in that part of the world. And then now we get further information that these pulmonary nodules are not in a classic perilymphatic distribution. That doesn't necessarily mean it can't be sarcoidosis or some other type of process, but I think right now we have to be in the mindset this is TB unless proven otherwise. Last time I said that, I got it wrong because it was sarcoidosis. But I think that's still the mindset though. You have to make sure you rule that out. Because that could kill someone. Sarcoidosis I think it's more indolent than TB. So, that I would basically, be sending off into TB quant gold. But to be honest, even if it comes back positive, it won't change much. I would get a sputum sample and try to see if there's something else I can maybe like safely biopsy to test for TB and other infections. I'm trying to think other like nocardia, sure. I think Elena mentioned, like we have to look for Yaz it was. And pregnancy itself can be immunosuppressant, but the studies they're complicated. So some say that actually pregnancy can raise your immune system response, which is why MS can actually go up in prevalence in pregnancies, but then there are certain infections that can actually get more likely to spread and infect the host, specifically viral. I don't know about TB and other fungal infections. I would imagine they still would have an adequate immune system, but there is reports. Sorry, I'm family medicine, so that's why I know some will be. So it's just like this kind of like slowly bringing back thoughts from my residency. But the last thing I wanted to say was there have been reports that TB is more likely to be reactivated during pregnancy. People don't know why, but that would be my other additional thought to put this.
Yeah, Justy, that's a really important point, that reactivation, and this also should drive our testing. So I absolutely do agree. Doing quantiferon, we're looking for latent, but we do need to get AFB. We do need to get then simultaneously doing a NAT on top of that to make sure we're looking for if this is TB, is this active. We also have to glance to maybe MAI as well, atypical forms of mycobacterium, but MTB definitely is front and center in this discussion. And then we're kind of like, now we're focused, the lung has become sort of the center of gravity of this case, but like neurologically, what's going on? Has this affected the brain as well? And there are various manifestations of TB in the brain. I mean, inflammation by itself, like John mentioned, this scan mnemonic. So stroke-like situations, I didn't even go through the 6S. A lot of people know, Yasmin knows the 6S. First it was 4S, became 5S, became 6S. So sugar, syncope, we are thinking about stroke, sleepiness, substance, and then psychogenic. The last S is psychogenic. So, and we have gone through those, but now considering what is in the brain, the CT has not shown anything really. So, and what does the CT show us initially in a brain attack rapid response or a rapid response is if there's maybe a mass that could be causing neurological deficits, stroke-like features. You can also get non-convulsive status epilepticus, where you won't get seizures, but I mean, we're not dealing with that. This patient is telling us is some numbness and tingling. TB can manifest in this way. There's various ways where you can have a tuberculoma, you can have tuberculous meningitis, and you can also have spinal cord TB with more focal neurological deficits, but you also have compromised bowel bladder function as well in that case, which we're not getting here. Yeah, John hasn't mentioned any bowel bladder issues. And then usually TB, when it does involve the brain, it involves the base of the brain. So you'll get accompanying neurological, like cranial nerve deficits in this case. So all the cranial nerves exiting the base of the brain will become dysfunctional, and you'll start to see all sorts of cranial nerve pathologies. So I'm trying to figure out what is the relationship, or is it just like a remote relationship where you have TB and the inflammation is causing this manifestation in the brain. So again, it's just sort of cycling the brain to see what exactly or where should my testing be. But definitely, yeah, do the tuberculous testing, and then also gain history, right? So we have a patient that is pregnant, is coming from Afghanistan. So we need to do the usual HIV, syphilis testing, hepatitis, and so on, and see if any one of those are positive, and then that helps us to then solve this problem further. Maybe there is a major immunocompromised background in this patient. Anything else, Jasdeep, come to mind before we go back for the next aliquot?
No, I think that was brilliant. I guess one question I want to ask, like either you or like the audience, is like, I'm trying to see if I can somehow connect the dots between a possible TB diagnosis and her initial presenting symptom. Like, I think can TB infiltrate into the nerves and cause some type of around the nerves and cause that type of a neuropathy, or is this now TB to the spine? And it's causing like radiculopathy from there. Like that's something that I'm struggling with. And I would, I don't know if you had that initial thought of like how you can connect that, because like I'm looking back to what this patient was initially having and what she came in with.
So Jasdeep, I want to springboard from that. That's absolutely, it's interesting, the play between the thoughts that are coming from you and me kind of, and I didn't focus attention. That's why problem representation is important. I completely kind of forgot headache, right? So headache was one of the manifestations, regardless of all the other accompanying signs and symptoms. But when you have headache, maybe that is a signal for TB, probably manifesting in the brain. So another sort of involvement of TB, we talked about meningitis, but tuberculous abscess. I mean, I guess that would have been shown on the CT, but that can cause headache as well. So maybe there's many manifestations. Now, Gabby did a schema a while back on all the possible TB manifestations in the brain, which is like tuberculous abscess, tuberculous meningitis we talked about, brain tuberculoma, and there's a few more. Spinal, we talked about spinal tuberculosis. POTS, I remember, which is different. I don't think we have POTS here, but those I'm missing maybe one or two if anybody remembers. But those are a few things. So maybe that headache was a signal for a involvement in the brain. So maybe we do have to follow up with an MRI. But rapid response, so on. I think this patient is exhibiting stability. Vital signs are stable. Blood pressure, like you mentioned, is stable. There is slight anemia, which is expected, but not requiring an urgent transfusion. So we have time to, and the patient has a protected airway, no arrhythmias, and so on. So we have time to decipher through this problem. Back to you, John.
Okay, nice discussion. So let me give you some basic labs next. Chemistry, sodium 134, potassium 3.8, chloride 101, bicarb 23, BUN 11, creatinine 0.43, calcium of 9.1. LFTs are normal, the AST 12, ALT 8, total bili of 0.3. Albumin is 3.0, total protein is 8.0. And the CBC, white blood cell count of 12.0, 75% neutrophils. Hemoglobin is 10.2, MCV of 76.2, and the platelets are 436. And so I'll give you like a bit more in the kind of in the interest of time too, to round out this aliquot, include got an MR. We ended up, thinking about how to localize this and where to look with our imaging. We had, like headaches, question of trouble finding her words, and also her her leg is numb. So we, ended up getting an MRI of the brain, and Swinbig just MRI'd her entire spine. So the brain, there's non-specific areas of abnormal signal along the left sylvian fissure involving the insula and temporal lobe, with additional areas of abnormal signal in the dorsal pons. In the MRI of the spine, non-specific abnormal signal, similar description as the brain at the C3, C4 level. And there's multifocal marrow abnormality in the thoracic and lumbar spine. There's multiple areas in the bone. And kind of here's like the most significant abnormality is the left ventral epidural space at the levels of T11 to L1. There's this epidural like tissue. It's expansion that's extending into the neural foramina, and it's also extensive dorsal and right ventral epidural tissue at L4, extending into the right neural foramina, causing significant spinal canal stenosis. So in summary, it's multiple non-specific areas of signal enhancement in the brain and the spine, and this abnormal epidural tissue extending out and causing spinal stenosis. So I'm going to give you next to it, some of the next things we got including some additional workup, but maybe let me turn the mic over to try to digest the MRI findings, and perhaps for the folks in the audience, a good time to try to put together like a summary statement or problem representation. If anyone has a good one they're willing to share, like put it in the chat or unmute yourself and share it with the group. So with that, let me turn the mic back over.
Absolutely amazing findings, and thank you, John, for putting this together and presenting it in such a fashion with a opening statement of a rapid response or in an emergency in labor and delivery. But yeah, I think Jasdeep, we were kind of discussing or exchanging ideas that I think this lung findings was totally not unexpected. And it's not unusual because there was no shortness of breath. There's no real, I mean, although 94% on Romer, but it's not 85% where you would look at the lungs, and then the pulmonary exam is clear. So there was nothing there to identify or anticipate that there was going to be such a finding in the lungs. But of course, we were focusing on the brain, and then we were thinking about, okay, this radiculopathy, is the spine involved? And we really do see a lot of pathology within the spine. So I guess now we have to, I think I really like what Hans put in there. He was putting together a couple of his thoughts. Hans, I'm just going to sort of bring you in. If you could describe what you had put in the chat, sort of you put together a problem representation, and we'll add the spine findings to that.
Yes, I was looking at her chief complaint, which is a burning sensation and numbness in her leg for 3 to 4 days. So it's not acute. Yeah, it is still acute, but it's not hyperacute. It's been going on for some time. We were thinking about a stroke, but the infectious thought where she might have tuberculosis or maybe a fungal infection or anything that could affect her lungs first, maybe it's inhaled and then got into her bloodstream and then affected her brain as well as her spine, could explain everything from burning sensation, numbness, even difficulty speaking, etc. But what it is, I don't know. We probably need a biopsy.
Yeah, it's interesting. Yeah, definitely we do need to get some tissue. But we hypothesized somebody who's coming from Afghanistan. We hypothesized infection. There is a white count, not significant, but there's neutrophil predominant. Pregnancy is an immunocompromised state, not to the excess of maybe a condition like HIV or other conditions where you can be immunocompromised. So usually with pregnancy, if I've seen from experience, viral infections and so on, you tend to have more. I remember my wife when she was pregnant having more URTIs and so on, but no devastating bacterial infection or anything like that, luckily. But with this, it seems like there's an infection. TB is at the top of the list. And TB is one of the ones which is, we call it one of the great imitators, right? What can involve diffusive structures, lung, spine, brain, and definitely TB comes to mind. The other thing is then malignancy? Could this be a case of malignancy which diffuse metastases? But it's rather odd in that having such diffuse diseases, patients not having any prodrome of maybe malignancy. So there's not a lot of malignancies early in life that you would have, maybe sarcomas or connective tissue malignancies. But I think, yeah, definitely getting the test, figuring out if there's a case of active TB is probably the first order of the day, I would say. But I'll turn it over to Jasdeep. But just before that, pulmonary nodular conditions. I was just sort of talking about a case before. There was another person that was an immigrant, had lung pulmonary disease, was thought to have TB, had episcleritis. I actually presented this case. It was actually a case of GPA. So connective tissue disease. What kind of, before we even totally exclude connective tissue disease, what kind of connective tissue disease could cause diffuse pathology like this? So I mean, lupus can be one. It's also a great mimicker, but to have masses to this degree, probably not. I mean, there's always atypical cases, right? Just like another case I just had yesterday of first manifestation of lupus in a patient was lupus nephritis without the anti-Smith antibody, double-strand antibody complement, so on. Just the ANA was positive, but the biopsy showed a full house pattern, and it can happen. But lupus, unlikely. There's no also like a joint association or anything like that. No rash, no cytopenias, although we do have the platelets are fine, the white count, hemoglobin is fine. So I kind of will exclude connective tissue disease. I'm still on the TB bandwagon, but Jasdeep, over to you.
I feel like that's a better bandwagon than being on the Ravens. No, I'm just kidding. No, so I honestly, I'm satisfied with the spine imaging. I think that does explain, at least to some degree, that the numbness and the burning sensation that she was having. I'm assuming that this was just progressing over time and it eventually led to some compression of the cord or of the radiculopathy type of symptoms. And that's why she was having it in an acute distribution of 3 to 4 days. I loved your thoughts, Ravi, on possible autoimmune conditions leading to mimics. Honestly, I don't know too much about IgG4 disease, and I know David mentioned in the chat. I think that's a great. The one thing I know about it is one of those autoimmune diseases that can lead to masses. But one thing I do know about it is it's very indolent. It usually leads for months of symptoms before they come into the hospital. So the time course kind of is a little incongruent. But in terms of other infections, I know we talked about fungal, we talked about TB, and TB being highest on the list. I think the other, given the location, is melioidosis. But I don't know too much about melioidosis and whether if spine meds is something that melioidosis would do. So I think right now, I would definitely want to see if I can, I guess the main thing I like, the fact that they had severe stenosis, I would just clarify with the patient if she's having any type of like urinary incontinence or saddle anesthesia where we have to get like neurosurgery or ortho on board. But yeah, so I'll turn it over to John. I'd love to know what else is,
just before we do that, it was interesting, melioidosis you mentioned. We did have a case of that, and the circumstances was a patient was in a flood. And melioidosis is one of those ones where you have brackish water, or I guess flood-like conditions can lead to acquisition of that infection. And then just commenting about TB, what we see on the spine are these sort of lesions, and TB can cause these tuberculomas, coalescing tuberculomas, which can give you this sort of pattern. So again, that's another point for TB in this. But you know what? I don't know. I definitely would do the diagnostic testing here. So which would be doing AFB, getting the quantiferon, and if the AFB positive, we have to confirm with NAT. But we'll turn it over to John.
All right. So let me start off with some of the, in the order of operations, some non-invasive things that we got first. So we did some, COVID, flu, RSV were negative. So she wasn't able to give us any sputum and try to get like induced sputum, so we weren't able to get samples for that. Syphilis immunoassay was negative. HIV was negative. Urinary histo/blasto antigen kind of has overlap for both of those, is negative, and there's some antibody from the serum as well. Cryptococcal antigen in the serum was negative. Fungitel was sent for whatever weight you put in that, which was negative, and ACE level was normal. A quant gold was sent, and it was some real life for you. It was non-diagnostic. The mitogen tube, which serves as the positive control, gave a low response. It says which could be due to suboptimal pre-analytic handling. So that one is not really diagnostically helpful one way or the other. An echocardiogram was obtained. There's normal LV and RV. There was no evidence of any vegetations. And I'll give some more information. So we consulted multiple different specialists, and pulmonary ended up doing a bronchoscopy, and so the first pass from that is negative gram stain. Bacterial culture is growing normal respiratory flora. Cytology with mixed inflammatory cells, no malignant cells. I don't think they didn't send, there wasn't like CD4/8 subsets sent. And some of the other cultures at this point in the case are pending. So next we decided to get a lumbar puncture. So sample the CSF. So in the LP, the glucose was 30, protein 53. There's 53 white cells, which is 64% neutrophil, 20% lymph, 16 monocyte. An ACE level in the CSF was normal. The CRAG was negative. The adenosine deaminase was 3 with a normal range of 0 through 9. And IgG was 10.9 milligrams per deciliter. IgG index 0.7. There's no oligoclonal bands. Opening pressure was 18 centimeters water. And actually, so we sent a MTB nucleic acid amplification test from the CSF, which results negative. And I'll kind of let you digest that information, and then the next aliquot will reveal the diagnosis. And
What do you
in the
think?
chat, yeah, I think that the nodes were a little too small for them to reliably get, but they got some, they did a lavage.
Yes, Steve, what do you think?
Oh man. John, what a great case. So many twists and turns. So I think the sending out the histo and blasto antigen was like, and I didn't even have cryptococcal on my mind. I think that was a great send out, especially with the lung findings. But blasto, I have proudly stumped Ravi and Reza twice with the blasto cases. So blasto, anything TB can do, blasto can do better. I'm gonna trademark that saying if it ever gets famous. But I think that was a great send out test to see if this was a case. I'm very surprised by the MTB negative. I think the LP findings is consistent with with increased white counts, for me to be concerned for like an CNS infection, especially with the neutrophils and even some lymphocytes too. Now the glucose is not terribly low. I don't remember the normal range off the top of my head, but it's not low to the point where I'm concerned for a bacterial infection. And shout out to Yusuf, who does a great job of explaining the glucose. He goes, the way he sees it is like bacteria eating glucose. Well, then I try to think to myself as like, okay, if there's a indolent process, an indolent bacteria, then it's probably eating the glucose at a slower rate. Protein is not significantly high where I would be concerned for like, demyelinating or neurological consequence. So the MTB is negative. However, when I summarize this case, an individual who is from an endemic area has very concerning imaging findings for possible like tuberculosis masses. And, you know, LP findings concerning for like a impossible infection. And what I know about the slight increase of activated TB happening in pregnancy, I feel like this is something I would want to like maybe do another repeat biopsy, and see if we can get better tissue, or maybe giving some more time for cultures. You know what's funny? I feel like if we were in Afghanistan, or if we were in India or a person, I feel like this patient would have already gotten started on right therapy. And what I do know about right therapy in pregnancy patients is it crosses the placenta, but it doesn't they don't have any associations with fetal toxicity. And I feel like if this patient was getting unstable, that's what I would be considering in real time, even with the MTB negative. Ravi?
Yeah, I think does this exclude? I mean, I like the breakdown that you did. What I was kind of trying to digest is what can I glean anything from this CSF? So we do see, like you did a very good job of going through glucose, protein, the white cell count, and it's pretty much polymorphonucleic predominant, less lymphs. So this indicates more of a bacterial, maybe possibly fungal as well. In this case, monocytes, I was just trying to think, does this give us anything? I mean, monocytes are usually, they go in there, and if you have some blood or something, they're sort of like the vacuum cleaner. They go in and clean up, but it doesn't give you, or it doesn't discriminate between, or help you to discriminate between bacterial, viral, and so on. So it doesn't give us a lot to really work with. So I will just take that and kind of jettison that thought. And yeah, I think at this point, maybe we need to get a biopsy of these lesions to really see what's there. You get a biopsy, you can then determine, is this granulomatous? If it's non-caseating, it could be something like sarcoidosis. If it's caseating, then it could be any one of the granulomatous diseases, and you can run the whole gamut of them. But we definitely need to do direct testing on maybe some tissue. The diagnostic testing is sort of is not getting us to the answer here. So we need to go get a bite of probably that lesion in the back, if possible, and see what is causing all this pathology. What do you think, John?
Yeah, I think we were kind of right there with you with that, with some of those thoughts. We have some like discordant information that we're trying to digest here, and like even some debate amongst the leading diagnosis between the different consulting teams. And that's one of the things, actually, one of the the radiologists who read the CT described the thing as like consistent with sarcoidosis. And then like we have the CSF fluid that's it's neutrophil predominant, and the nucleic acid amplification test doesn't grow any TB. So we're stuck in, didn't have a definitive diagnosis, but there's a lot of risk factors. So we ended up, you're kind of thinking, whenever you have, don't get your diagnosis by your labs and by your history and exam, kind of tissue is the issue, and trying to figure out where is the least invasive way to get it. And I like how people in the chat were thinking like it could be get like the mediastinal lymph node. I think that one of the they described them being a little bit too small to reliably target. So we did end up going after that abnormal like epidural tissue. The neurointerventional radiology was able to get a sample of that. So that is what that was the first thing that gave us the diagnosis. So actually the MTB, nucleic acid amplification test from that epidural tissue, was the first thing that came back as positive for MTB. And subsequently, after some delay, the bronchial sample from the bronchial wash eventually turned positive as well. And so the patient was started on 3-drug regimen for TB. They excluded ethambutol because there's like just some like little relative paucity of data for safety and pregnancy. I think understand that's kind of a controversial topic. But she over the course of the hospital stay, she had some ups and downs, had some, some spiking some fevers and some episodes of hypotension, but she, ended up doing quite well. She completed her treatment. She delivered a healthy baby, followed up, and had her symptoms were like described as being like resolving. Some things I looked into. We had some really. I was scratching my head how to like put some of these points together. So it's like I looked, was looking into some of the test characteristics. So like the gene experts, CSF nucleic acid amplification, the sensitivity ranges in different studies from between like 50 to 80%. And the adenosine deaminase levels as well. Like actually their test characteristics for that 75 to 94% sensitivity, 86 to 97% specificity in the different studies. And we also had the CSF didn't end up being positive in our case either. So I was trying to put this together, like perhaps just had a relatively lower burden of mycobacterial disease in the CSF, and it was all like kind of concentrated in that epidural space. And I think this just it was another nail in another point telling me just that TB is just so notoriously difficult to exclude, and ended up being the diagnosis something we were thinking of early on, and then got some discordant information along the way, and there was some debate about whether to empirically start treating early, but then that epidural tissue was the kind of the center in terms of our hospital diagnosis.
Wow, John, that's an absolutely amazing case. I just love it. Even this case, it's not always the diagnosis, but what a journey that we've been on. Just starting with this, just arrival at I could just kind of I felt like I was right next to you, just seeing this patient, the way you described the situation, and not having all the information on hand. So when you arrive at a rapid response, you don't always have that information. So you have to quickly think on the spot to make sure this patient is stable, go through. I love that scan mnemonic. I will be adopting it into my also teaching alongside the success and so on. And then also making sure this patient is stable, but then getting more information. But we had to be careful when you mentioned Afghanistan. There's TB, but we're kind of like moving to TB and away from TB, to TB, away from TB, and considering other causes. But we couldn't neglect the gorilla in the room, which was, possibly TB. And it's like somebody mentioned, TB can masquerade as anything. And then the tests, it's amazing. I was thinking, the sensitivity, specificity of all the tests that you've done amazing, all these diagnostic tests, but they're not always certain. They don't get you the answer. And it's just interesting, like you mentioned, that these tuberculomas in the spine were not just spewing sort of this bacilli into the CSF to give you the answer. So that's absolutely amazing case. And occasionally we do come across cases like this with TB, and I'll be sure to remember this case and use it in working up such a patient. So thank you for putting this case together. And we'll move on to teaching points with Anmol.
It was a really amazing case. Thank you so much. And I loved how it was beautifully discussed. So if I talk about the teaching points, initially we had this pregnant lady who came up with burning sensation and numbness for 3 to 4 days. So basically, a stroke alert was called upon because of her symptoms. But we see that we need a thorough neurologic examination for code stroke. And if actually, while awaiting the CE results, we think of a code stroke, what could be the possible causes in a pregnant lady which can lead to code stroke? So there can be complications of pregnancy like amniotic fluid embolism, but that is mostly during the times of delivery. Or there could be thrombosis, and because pregnancy in itself is a thromboembolic state. And also, again, we saw that this was a young girl who was having symptoms of numbness and burning sensation in hands with progressive worsening of symptoms. That is, the symptoms were not hyperacute. So it could indicate more of a spinal cord problem or a nerve compression in the cervical region, more than a cold stroke, these burning sensation and numbness symptoms. And then we thought about the mnemonic for altered mental status, that is scan mnemonic. That is how we rule out the emergency causes for altered mental status by checking the serum, by checking glucose, which can mimic stroke-like symptoms, and then doing a CT scan and going for an ABG and checking for narcotic overdose by examining the pupils. Then we have another good mnemonic for a loss of consciousness, that is 6S, which could be sugar, syncope, stroke, sleepiness, substance, and psychogenic. And then we came over to this imaging of the chest, and we saw that the patient had nodular lung lesions. So what could be that? It could be anything ranging from infections, inflammatory, autoimmune, and tumor causes. How to evaluate and come out to the main cause. So we look for the distribution or pattern of the nodules, if it is centrilobular or perilymphatic or randomly distributed. So this patient seemed to have randomly distributed nodules, and what could be the possible causes for that? It could be septic pulmonary emboli from, for example, an infective endocarditis, or it could be histiocytosis or pulmonary metastasis from any tumor or miliary TB. Then again, we saw that pregnancy in itself is a state of immunocompromise, but considering this case, it would be important to know the immune status of the patient also, checking for HIV and hepatitis panels. And the history of prior chest infection also raises concern for a reactivation of TB. And now we are coming over to the differentials of TB, melioidosis, metastasis, infiltrative diseases like IgG4, autoimmune like GPA or lymphoma, or endemic mycosis. So to just confirm our diagnosis or to rule out certain diagnoses, we need AFB, NOT, LDH, for if we suspect lymphoma, or lymph node biopsy, which could be taken from the hilar or mediastinal lymph nodes. But as Dr. John said, that they were not accessible. And then also we saw so many lesions in the lower down lumbar spine. So we also need to check for bowel or bladder deficits if they were present, so that if we have to go for a neurosurgery consult because of that. Then we thought about if it, we were really concerned about it being TB. So we think about the ATT or the RIPE therapy. So we think that it, and to think if we can give that to a pregnant lady, it can cross placenta, but it does not necessarily cause any toxicity to the fetus. But talking about the ethambutol, it is a little controversial. The rest of the other drugs are fine. And then we saw ultimately the patient was diagnosed with TB. So, so we just saw that sensitivity and specificity of the test for TB is really unreliable. And as everyone at CP Solver says, that one can never really rule out TB. And then the patient was diagnosed with disseminated TB. And that's it from my side. Thank you so much.
Thank you very much, Anmol. That was absolutely spectacular. You got all the important points for this case there. And thank you, everybody, for logging on and spending this evening with us. It's probably 6 p.m. East Coast time. And tomorrow we have Charmaine and Jack at 1 p.m. for another CPS discussion. So see everybody tomorrow. Take care. Have a good night. Bye.